Welcome to Introduction to Healthcare and Public Health in the U.S., Financing Healthcare, Part 1. This is Lecture C. The component Introduction to Healthcare and Public Health in the U.S. is a survey of how healthcare and public health are organized and how services are delivered in the U.S. It covers public policy, relevant organizations and their interrelationships, professional roles, legal and regulatory issues, and payment systems. It also addresses health reform initiatives in the U.S. The objectives for Financing Healthcare Part 1 are to describe the history and role of the health insurance industry in financing healthcare in the United States, including federal laws that have influenced the development of the industry. Explain the importance of the healthcare industry to the U.S. economy and the role of financial management in healthcare. Describe models of healthcare financing in the U.S. and in selected other countries. Explain the differences among various types of private health insurance and describe the organization and structure of network-based managed care health insurance programs. Describe the various roles played by government as policymaker, payer, provider, and regulator of healthcare. And describe the organization and function of Medicare and Medicaid. This lecture explores how the healthcare systems in the United Kingdom and Canada are structured, discusses the benefits and drawbacks of these two primarily public-funded healthcare systems, and compares the multi-payer system of the United Kingdom with the single-payer system of Canada. It also discusses the role of private insurance in each of these tax-funded systems. Many countries provide government-paid basic health care services for their residents. These services are usually funded by general taxes, payroll taxes, or a combination of both. How this publicly funded health care is structured and delivered varies from country to country. Privately purchased health insurance may also play a role in these public healthcare systems. As mentioned in Lecture B, the U.S. healthcare system is a mixed model of private healthcare organizations and government-operated systems. Other countries also operate mixed delivery systems. Two of these are the United Kingdom and Canada. However, the methods that these countries employ to deliver and finance healthcare services is quite different from how it is done in the U.S. Both the United Kingdom and Canada fund basic health care, primarily through general taxation. However, the United Kingdom has a multi-payer system that includes private payers, while Canada has a single payer in each province and territory and relies little on a private system. In the United Kingdom, health care is centrally administered by the Department of Health. The department distributes funds to single-payer systems in 5 regions of the country. With some exceptions that will be discussed later, healthcare services are primarily provided at government facilities by government-employed providers. It is the prototypical socialized medicine model. In Canada, the Federal Health Canada Department administers a program called Medicare, in all capital letters, which distributes funds to provinces and territories. These regions are similar to states in the U.S. The provinces and territories use the federal funds, along with regional funds, to administer their own provincial or territorial healthcare plans. Each plan must meet certain national standards, and services vary by province and territory. The single-payer system of the United Kingdom's Department of Health funds the National Health Service, or NHS, in 5 regions of the country: England, Northern Ireland, Scotland, Wales, and the Isle of Man. The health plan in England is called the NHS. The health plan in Northern Ireland is called the NHS Northern Ireland. The health plan in Scotland is called the NHS Scotland, and so on. 10 regional health authorities run the NHS and distribute funds through primary care trusts, or PCTs. Primary care trusts maintain contracts with healthcare providers and hospitals in each NHS region. Healthcare providers and hospitals are paid through the primary care trusts. The primary care trusts pay healthcare providers in a variety of ways. Some providers receive a salary and some receive a fee for service. Some are paid through capitation, which means they are paid a fixed fee for each patient in their practice. In 1946, the British Parliament, the legislative body in the UK, passed the National Health Service Act, which authorized the NHS. This act was part of a group of laws designed to strengthen the social safety net for British citizens after World War II. The NHS began covering medical services in July of 1948. The goal of the NHS was to provide free, tax-funded health care to all British citizens, regardless of their income. Before the NHS was established, many British residents could not afford to go to a doctor. The NHS was an ambitious and controversial project. There was stiff opposition to it from the British Medical Association, which represented Britain's doctors. The association was afraid that doctors would lose their independence and earn less money if they left private practice to work for the NHS. To persuade doctors to join the NHS, the health minister at the time, Aneurin Bevan, said that if they worked for the NHS, they could also maintain their private practices. He famously said that he was stuffing their mouths with gold to convince doctors to join. His approach worked. Ultimately, 90% of British doctors joined the NHS by the time it began providing services. The United Kingdom's Department of Health administers and provides tax money to the NHS. The Department of Health is accountable to both the public and to the government for the performance of the NHS. The Department of Health is also responsible for improving public health through other programs, such as protecting people from environmental health hazards and ensuring medication safety. The department sets national health policies and helps to develop and deliver services such as health education. In 2013, the most recent year for which data is available, the per capita spending by the NHS was $3,595, which was 39% of the $9,255 per capita spending in the U.S. In 2013, national taxes funded 76% of the NHS budget. A payroll tax called national insurance paid for another 18%. The remaining 6% of the NHS budget came from fees paid for access to NHS services by private insurance patients, fees paid out of pocket by NHS patients, and other sources such as philanthropy. Today, every person who lives in the United Kingdom can receive health care through the NHS. This is called universal health care coverage. The NHS pays for a patient's primary care with a general practitioner, also called a GP, who refers patients to specialists as needed. Hospital care, specialist care, and preventive care such as vaccinations and cancer screenings are covered. The NHS also pays for other health care such as mental health care, rehabilitation, dental care, and long-term care. Eye care is covered for children, full-time students, elderly and low-income patients, and people with diseases that affect the eyes such as glaucoma. All NHS services were free until the early 1950s, when the NHS began charging some fees for prescriptions and dental work. Today, cash payments made by NHS patients are modest. In 2007, the average citizen paid the equivalent of $343 out of pocket for healthcare expenses. By comparison, in that year, the average U.S. citizen paid $890. NHS patients now pay a fixed rate for prescriptions, but there are fee exemptions for certain populations, such as cancer patients, low-income patients, and children. Dental costs are capped by procedure. Although the publicly funded NHS provides a wide range of healthcare services, about 12% of residents either have employer insurance or they pay for private health insurance. The most common reasons are to expand their choices of doctors and healthcare facilities and to reduce wait times for non-urgent medical care. Private insurance provides patients access to both NHS and private hospitals. Greater access to care decreases the wait time to see specialists or to obtain medical procedures at NHS facilities. The NHS is currently working to reduce wait times within its system. The goal is to reduce wait times for hospital specialist visits to 18 weeks or less. After the 2010 general election in the United Kingdom, the new government proposed to decentralize the financial and managerial duties from the regional and local health authorities and transfer them to local control by general and specialist physician groups, nurses, and consumer or lay representatives. This was based on the notion that general practitioners and specialist groups are more familiar with the needs of the patient population of a particular area. Each of these groups would determine which medical services to provide for the population it represented. The local groups must continue to provide for the urgent and emergency needs of the population and address ongoing health and social needs, and ensure patients' interests are protected through monitoring quality and efficiency outcomes. Like the United Kingdom, Canada provides taxpayer-funded universal healthcare coverage for its citizens and permanent residents. As mentioned earlier, Canada's National Health Insurance Program is often referred to as Medicare in all capital letters. But unlike the United Kingdom, the Canadian Constitution states that the federal government cannot run regional healthcare plans. As a result, each of Canada's 10 provinces and 3 territories runs its own healthcare plan. Funding for these multiple single-payer plans comes primarily from the federal government, but regional governments also contribute to the costs. Canadian public healthcare has more variety between regions than the public healthcare plan in the United Kingdom. The Canadian plan also has some unique limitations on what private health insurance covers. The modern healthcare system in Canada began in April of 1984 with the passage of the Canada Health Act. This act updated earlier laws from 1957 and 1966 that had helped fund healthcare in Canada. The Canada Health Act, passed in 1984, was designed to increase access to and limit costs for healthcare. It set national healthcare criteria, such as universal access to government-paid medically necessary services for everyone. Provinces and territories are required to follow specific guidelines. Today, provinces and territories receive income tax money from the federal government to pay for approximately half of their healthcare expenditures. The amount of federal money each region receives depends on its population, with low population provinces receiving additional federal funds. The provinces and territories must provide the balance of the financing for necessary services. Some provinces and territories supplement healthcare funding through sources such as lotteries, sales taxes, or healthcare premiums. Patients who cannot afford the premiums still have the right to receive healthcare. The Canada Health Act uses public funds to pay healthcare providers who generally are in private practice. There is a dichotomy between institutions and organizations and providers in the Canadian system when compared to the NHS in the UK. Most hospitals in Canada are public institutions funded through the provincial or territorial health programs. At the same time, the Canada Health Act uses public funds to pay healthcare providers, who are mostly in private practice on a fee-for-service basis. The Canada Health Act of 1984 includes 5 principles that govern provinces and territories if they want to receive federal funding for their healthcare plans. These principles are public administration, comprehensiveness, universality, portability, and accessibility. The first 2 principles explain how a health plan must be administered by the province or territory. The public administration principle states that a public authority must administer the health plan in each province or territory. This authority must run the health plan as a non-profit organization, and its accounts can be publicly audited. This principle prevents provinces or territories from giving public funds to residents to pay for private, for-profit insurance. The comprehensiveness principle states that all medically necessary services must be covered by the health plan. Provinces and territories have the freedom to determine which services are medically necessary and which are not. The last 3 principles explain the rights of patients within the healthcare plan. The universality principle states that all Canadian residents should receive the same level of care within their province or territory. The portability principle states that residents must receive healthcare coverage if they travel outside of Canada or if they move from one province or territory to another. This principle also ensures coverage during the brief waiting period to join a health plan when residents move between provinces and territories. The accessibility principle states that every resident must have access to healthcare regardless of their health, age, or income. Healthcare providers must also be adequately paid for their services. Canada's provincial and territorial healthcare plans must pay for services considered medically necessary. These include preventive care, hospital stays due to illness or injury, medical equipment, and dental surgery. The Canada Health Act does not require that provinces and territories pay for so-called extended healthcare services, which means services not considered medically necessary. These services can include prescriptions, eye care, and routine dental care. Most provinces and territories choose to fully or partially cover some of these services, although coverage options vary by region. On average, each Canadian spends $580 per year on out-of-pocket healthcare expenses not covered by Medicare. About 2/3 of Canadians purchase private insurance to supplement Medicare services. Often, employers offer private insurance as a benefit. Private insurers in Canada cannot legally pay for services already covered by Medicare, which makes Canada unique among other nations that provide publicly funded healthcare. The Canada Health Act limits private insurers in order to keep the system equitable for all. Private health insurance provides approximately 30% of Canadian healthcare expenditures. The other 70% comes from public funds. Limiting private insurance has two primary effects. First, patients cannot purchase private insurance to improve their access to basic medical services covered by Medicare. Second, limiting the ability of some people to opt out of public health care increases the public cost of universal care. Some Canadians would like private insurance to play a greater role in Canadian healthcare. Others want to continue to restrict the role of private insurers in order to ensure that everyone has equal access to basic medical care regardless of income. Despite its drawbacks, the Canada Health Act has contributed to public health achievements in Canada. Life expectancy and infant mortality are two measures often used to compare the effectiveness of healthcare in different countries. Life expectancy at birth was more than 80 years in 2005, among the highest life expectancy in the group of 7 countries, which are France, Italy, Germany, Japan, the US, the United Kingdom, and Canada. Canadian infant mortality was cut in half from 1979 to 2005. This concludes Lecture C of Financing Healthcare, Part 1. In summary, the public health plans in the United Kingdom and in Canada reflect the different social and political priorities of each country. Both the United Kingdom and Canada provide public health care coverage for their residents, funded primarily by taxes. The United Kingdom's multi-payer system is centrally funded and administered. The United Kingdom lets residents purchase private insurance to have greater choice and faster access to many healthcare services. Canada's single-payer systems are funded through federal and provincial taxes. Provinces and territories administer their own healthcare plans, as long as they follow certain nationwide rules. Canada is concerned about providing equal access to all residents and permits residents to purchase private insurance only for services that the public plan does not cover. Both countries have worked to reduce long wait times for medical services in their public plans.